Thanks everyone for joining us. I'm going to wait about one more minute to let people log into the webinar, and then we'll get started. Okay, hi everybody. Thanks for joining us. My name is Chrissy Giuliano. I'm the Executive Director of the Big Cities Health Coalition. BCHC is a forum for leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to promote and protect the health and safety of the nearly 62 million people they serve. You can see the map up on the screen in front of you. And again, we really thank everyone for attending today. We're so pleased to be able to have this important discussion. So we're going to go over a few housekeeping information. If we could go to the next slide, there we go. So the session is being recorded, just so everyone's aware. Everybody's lines are muted except for myself and Patty Hayes, our speaker. You can use the raise your hand feature if you can't hear us or if you're having other technical difficulties. You can also chat Gabrielle Nichols in the chat if you have a technical issue. And then you can also use the chat feature to share questions, which we'll get to toward the end of the discussion. So we have with us today Patty Hayes, the Director of Public Health, Seattle and King County, a metropolitan health department of 1,500 employees, which serves 2 million residents of King County, including the city of Seattle. It's the 9th largest local health department by population in the country, and really provides a full complement of public health services, including epidemiology, communicable disease control, environmental health, jail health, emergency medical services, coordination and delivery, and medical examiner services, and a countywide community health center system. Prior to becoming director, Patty led the department's largest division, the community health services. She has over 30 years of experience in public health, policy development, and advocacy, both inside and outside of government. In November 2017, Patty was named one of the most influential people of the year by Seattle Magazine. She has a nursing and master's degree in nursing from the University of Washington School of Nursing and was inducted into the Washington Nursing Hall of Fame in 2002. So thank you, Patty, so much for being here with us today. I know things are very busy, so we appreciate your time. So let's just jump in with some questions. So, many people know Washington State saw what at the time we at least thought was, who knows if it really was, the first US case of COVID-19. So tell us a little bit about the early days, what your initial response looked like, what you were planning for, knowing that it would be more than just one case, and as the state's largest metro area, that you would see, large portions of that outbreak.
Yes, well, thanks, Chrissy, and thanks to everybody on the call today. It's a privilege to do this and to chat with all of you. One of the things that I think is important to remember about those early days in the Seattle area is that we didn't have a huge knowledge of the virus. And so a lot of what was going on during the outbreak we had here became lifetime science in action. And I think the reason that's important to remember is because we didn't know at the time there was pre-symptomatic transmission, for example. We didn't understand how the virus was going to be acting on surfaces at the time. There was just so much. So what that meant in terms of our response, and actually one of the things that will always make me remember this, not that any of us will ever forget this, but I was actually flying back from the Big Cities Health Coalition when I got the call about our nursing home outbreak. But we had already been in preparedness mode and in deployment since the first case up in Snohomish County, where we were about half of that person's contacts were actually in King County. We were actively in case investigation, contact tracing at the time. We were watching. There was so much focus on the airports at the time, and Dr. Duchin, our health officer, and I, we were really pivoting to look at more what was going on in the community. So all that worked to our benefit for the explosion that came on the 28th of February when the Life Care nursing home happened and hit the news as the first cluster and then big outbreak in the United States. And I'll say a couple of things that we learned right away with that. Number one, because we didn't really have a huge amount of knowledge of the virus, and when it popped in the nursing home, two things were unfortunate and I think prepared the rest of the country really well. Number one is nursing homes are required under our state law to report to public health if there is incident of pneumonia and other respiratory problems. Particularly, we work with them ongoing in flu season. And this particular nursing home had a number of folks come down with respiratory illness. Now, we know it was COVID, but they had not done their due diligence to report. And you might have seen that Medicare HHS levied a heavy fine against this nursing home. This nursing home chain is still in the news. We've had just this last week another nursing they have here in King County with another 20 all at once come positive. So the work that needs to happen with the state regulatory agency, the public health department, and the state public health department really rose up as big learnings, number one. Secondly, because that reporting had been done, the emergency room in the hospital that was the core in Kirkland was caught by surprise. And one of our leading physicians over there in that emergency room actually came down with COVID eventually. He did recover. He was very, very ill. He was a leader both in front of the podium with me a number of times when we were talking about the outbreak. But the need for the hospital, they became very close, having to trigger into crisis standards of care, unfortunately. It also taught us very quickly that we needed the hospitals to work together, and we had to quickly get, and we have a pretty good network nonprofit that coordinates the healthcare industry partners, but they were caught unpaired. And so we quickly learned that we needed to help these hospitals develop a plan for their capacity sharing and to avoid Evergreen Hospital being overrun. So while all that was going on, which was really intense, we were able to get a CDC team out here almost immediately. And again, that really was both for the purpose of assisting us on site, but also with learnings that need to be done to prepare so that CDC could help the rest of the country. So we're really blessed by this amazing CDC team that came out, worked with us 18 hours a day, every day, for weeks with our health officer to develop strategies, to work and sense when we needed to begin. That they helped us begin to see that we were seeing cases weren't related to this nursing home. So that was the next trigger that made us go, as you've seen with other counties, move into community mitigation strategies away from containment in community mitigation very quickly, so that we could really attempt to get ahead of this as we could. So those early days were about quick system development. You had to have the relationships to build. It wasn't a trust building time. You actually had to have the trust in order for everybody just to step in. And we were able to call upon partners like Kaiser Permanente, who's been amazing here. They had closed a hospital down a number of years ago when our county executive called their chief executive officer to ask, what's the status of that building? Can we reopen that if we need surge capacity? Can we turn it into a COVID unit? Can we turn it into a capacity unit for non-COVID? They deployed their team up here from California in 24 hours to do a total assessment of the building. And I knew, that was a Friday, I knew by Monday what was possible. So all of that were big learnings on sort of what we all need to do all the time, that when something pops up, we have partners ready to lean in and go with us. So it was really important to see all of those things in those early days.
So Patty, let's talk a little bit more about the outbreak in the long-term care facility and the nursing home. What are some of the unique challenges that environment presented for you all, both in the response and then thinking about the impact on the broader community?
Well, of course, one of the things that we're finding in the long-term care facilities in general, this was a skilled nursing facility, but I want to broaden it just a little bit, is that many of those frontline staff are low-wage workers, and they often have more than one job. And so part of the thing that we saw happening very quickly was the outbreak spreading because the pre-symptomatic staff were working or were coming to work ill, and they were spreading the virus. So number one, that's almost a state policy issue on reimbursement and the regulation of these facilities. Secondly, we have to work all the time during flu season on infection control with facilities to begin with. So a crisis like this that really puts them over the edge because they're not prepared. So we've brought in additional infection control expertise so that we can have, we've developed actually a public health strike team to assist these facilities. Washington State has a unique law. We have something called adult family homes, which actually have the same acuity level as skilled nursing facility, but it's in a home-like setting with only 6 people, not necessarily run by a healthcare provider. Those are becoming a real hot now. Again, shared staffing, lack of PPE is a real problem across the whole long-term care system. And then I've got to say, one of the challenges we've got is that when you have corporate entities that own multiple facilities, having presence so that their medical officer, even if they have, many don't have one, if they have a medical officer or a lead nurse practitioner or PA, that person is feeling support, that can be a big problem with the big corporate entities. So all of those things were very challenging. And then when you take a pandemic where you're locking all the families out and you're isolating the vulnerable people and the mental trauma that is existing today, we are still trying to figure out how to reopen these nursing homes so that the families can visit their loved ones, or we can have the priest go in and do service. The really important things to folks are important for public health to keep in mind, because it's not just about the pandemic and the physical part of this. It is this incredible mental trauma that's happening right now.
So let's talk a little bit about that. And we've talked about this within the coalition, and you've talked about this with some folks. We've seen a lot on CNN or other news outlets about the impact on frontline healthcare workers of this crisis. And I know that more and more governmental public health departments are seeing similar trauma, for lack of a better word, really thinking about the last several months, and then also how long this response is going to go on, and is there going to be another wave. So can you share a little bit about what you've been seeing among your team, and also sort of what you've been saying and doing to support their work?
I think this is a really important conversation that we need to continue to have as the public health family. When you start with from a deficit place where we haven't had adequate funding for so many years, your bench strength is so light that it becomes a point where people are so dedicated, they're working 24/7. We've had staff that haven't had a day off 4 months, and that's not really, it's unconscionable. I just have to say that. But these folks have so much knowledge, and they're in a position where you can't just turn and say, okay, you take call this weekend. There's nobody there because of the level of expertise. And how our system begins to address that across the system, we really need to figure that out, because as I'm talking to colleagues across the country, we're all having this problem where our core people, everyone is offering us help. It's so wonderful. I mentioned Kaiser Permanente, they're a wonderful partner. They've offered us help, but it becomes a point where the staff is so overloaded and stressed out, and I would say exhibiting PTSD symptoms, and we don't know what they're dealing with at home and the other stresses in their lives, and not being around their own family and the choices they're making to just protect themselves and their family. To onboard somebody and get them to understand how public health works. You can't, for example, nursing. Many times nurses are seen as extremely flexible, and we are, I'm one, yay. But taking a hospital nurse and then putting them into a non-direct care setting where they're having to do other kind of work. Same thing with epidemiology. They don't all work in the same platforms, and even the data piece. It's just been really hard. And so we're trying to figure out how to support staff and begin to build in that help. It's true for health officers too. Those of us that have health officers that have a level of expertise that's actually the core at the national level. That's who Dr. Duden is, and it's terribly hard to figure out how to get him time off. So it's at the upper leadership all the way down to the front line. I just would like to say I would love to see the media spotlight a public health worker. I mean, we have folks on the strike teams I mentioned. They go right into the facilities. They're there. They are working 18 hours a day. And it is really demoralizing to them. Not that they don't love their colleagues and think that the support for hospitals that are calling, everything, that's all good, but when are people going to understand we in public health are actually there with them right away? So,
yeah. So, like many of your big city colleagues, your jurisdiction is incredibly diverse. And I know, in thinking about a response, there are things that you need to do to factor that in. I know early on, sort of before everything really, really exploded, for lack of a better word, I know you were doing a lot of work on an anti-stigma campaign and working with your community board and other partners. Can you talk a little bit about that?
Yeah, we're couple things put us in a good spot to really step into this aggressively. Number one, King County has a very strong equity social justice mission that fits very well with public health. So the fact that the county in which I sit, it's a priority. I had a lot of elected leadership support in this space. Then secondly, we have, through our preparedness grants over the years, developed a set of community health boards from our local communities of color so that they would actually be working on health issues with the health department back to their community. It was an incredible resource. And so when the pandemic happened, we formed an advisory group, a pandemic advisory group from those boards, as well as other community members and the faith community who work with us lockstep. They have all agreed to meet on a minute's notice if we need to view a document, look at our visuals of what we're putting out. We just used them last week on our directive that we did for masks. They really helped shape that. We wouldn't have done it correctly if they hadn't been involved. So that asset was essential. In the very beginnings of the outbreak, there was just because of the rhetoric that was happening around the country, really some reports of discrimination against Asian Pacific Islanders, particularly folks from China, Korea. And so we wanted to step up right away. And so we held a press conference and put out information with the State Human Rights Commission, with the Office of Civil Rights and the Seattle Office for Civil Rights. We all stood together and put out a campaign called Vices Don't Discriminate. Was just one of our pieces. We have this up at our website for anybody that's interested, but it's been really important to stand with community here. The story of what people experience and still do experience. For example, those listeners that are thinking about doing a mask policy, we ended up doing a directive rather than an order, and that was very carefully thought through, and we did it with the advice of our community health boards, because the potential for discrimination around masking and who's wearing masks, what type of masks, with the color of a person's skin, it brings up age-old racism in our country. And so we're trying to really step with the community in this and address the stigma and racism head on as we can while this thing is going through. And of course, the data shows, of course, that these communities are suffering more because of the pandemic. So there's another opportunity to really step in and raise that up so that people understand the impact of the virus for those communities. So we continue to do that work, Chrissy.
Great. So, some folks may be familiar with the fact that you had a large hepatitis A outbreak a year, 18 months ago in your homelessness communities. And so I know that you've put some thought into now the COVID response and those experiencing homelessness. So can you share a little bit about what you've been doing with that population?
Yeah, so let me start by saying we were really lucky that in the middle of the beginning of this in the nursing homes, we didn't have a large outbreak in the homeless community, because Seattle, like other big cities, we have a large homeless community. It's not really a homeless population, people who are experiencing homelessness. So we were able to get prepared. We developed some strike teams, but what I'll say is really important is that we thought through a strategy of the threefold. The first one was de-intensification of shelters. So we know that the shelter system is not the best for people's health. Everyone needs a home, but have people in shelter versus on the streets. So what did we need to do to that shelter system? So leadership came together and we developed a de-intensification plan to try and give more space, because people were basically right next to each other, sleeping in or in day shelters. So tried that. That required both the city and the county to open more shelters. That ended up, we had a lot of learnings in that area, because we had a couple shelters that had folks that had higher levels of chronic illness. And so we really wanted to make sure we were paying attention to that shelter. And when, by the time we were able to de-intensify it and develop a couple of other shelters, a couple of critical things were missed at the time. Number one, when we de-intensified, and this the chronic problem with cities and counties as they're trying to address homelessness, there wasn't enough hygiene center availability at the time. And so, for example, one of the shelters, people had to take a bus to go take a shower. Well, that's just not a situation at all. And what happened in this shelter as we de-intensified it with folks who were extremely vulnerable anyway is because of the staffing, again, is challenging for the shelter providers. And one of the staff, and we actually had a meningitis case because a volunteer brought meningitis into a food program. So we were dealing with Hep A, COVID, and meningitis all at the same time. So what we learned from that was you need to get hygiene, enough hygiene right on the spot. You can't expect to have this pandemic anywhere leveraged downward if you you're forcing people to move around. The second thing we learned is there are folks that really do better in a system where they have more medical supports. So how are you going to develop not just the isolation and quarantine piece for that, and I'll talk about that in a minute, but how do you bring more medical supports into whatever shelter or whatever system you've got? So the city, we increased the nursing availability there. Part of our strike teams was an infection control specialist, a nurse that would go in, do an assessment of every individual to make sure that someone was not so ill that they needed to be hospitalized. We found that all too often, actually, as folks are in a shelter and maybe looking like they're just sleeping, but actually they're very ill. So this nurse became a critical component. And then testing and an environmental specialist to help with some of the hygiene stuff. So it's quite an intense strike team. It's expensive. And I don't think that we talk about that enough with the federal government. I think there's a need to understand what that level of work is in the system. The second strategy we used was to develop isolation and quarantine. The county stepped in, actually purchased some hotels, leased some other hotels. We took the approach that we wanted to overbuild. We'd rather overbuild, expecting a large outbreak, than not have enough available. That's been to our advantage. These isolation and quarantine, we found that we needed to really change our strategy. At first, we weren't putting enough mental health support in there. We learned that the mental health presence on site, literally 24 hours a day, had to be present for people not just walk away. Then we again began to put more nursing there for the healthcare end of this to make sure that we were dealing with some of the other issues that the person was experiencing, and frankly, healthcare issues that hadn't been addressed in the past that now with the risk of COVID loomed large. And then our third strategy, we set up what we called assessment centers, recovery centers. We wanted a place where if we walked to a shelter and basically the whole shelter is ill, we would have a place where we could provide transportation for the folks to a safe environment where we could do testing on site. They could sleep there. We would have a place for them to stay until we got the test back. If they were COVID positive and didn't need to be hospitalized, they could go into the recovery center, and we would have, that was our partnership with Kaiser Permanente. They provided the staffing for that recovery center. And then if we're COVID negative but still had respiratory problems, they could recover, and we would be able to get them into the hospital if they compensated. So that strategy is very intense. It actually costs about $1 million a month to run one of these well. That has a capacity of about 140 people. With where we're at right now in our outbreak, we've decommissioned one of those. We have one ready to set up on the second wave if we need it. So you can see how for us, this strategy in the space for individuals experiencing homelessness is multi-leveled. And I haven't even talked about the encampments. We have encampments here and we continue to have encampments, and there are folks that refuse to go into shelter. They don't like the shelter system. And we also have the CDC guidance that says don't take an encampment down unless you can basically house that person for tracking purposes. And that's a stressful space because some of these encampments are starting to pop up and blocking things, and some of the elected officials are trying to figure out what to do about that. It's a concern for safety in the neighborhood. I mean, it's very complex. I could talk for probably 3 days about that, Chrissy.
So I'm gonna turn to some questions that folks had when they registered, and then if other people who are on the line now have questions, feel free to put them in the chat. So sort of related, but at a slightly higher level. One of the questions is, we know there is and will be a surge in a need for behavioral health care generally. So how should cities start planning to manage that need? And what have you seen since the outbreak started?
So of course, whenever the economy tanks, which is what this pandemic is doing, it's tanking our economy to something akin to or worse of the Great Depression, it looks like, which is just frightening. We know that the Medicaid enrollment goes up, people are unemployed, there's more domestic violence. We've seen a rise in that. We've had an upsurge in gun violence in part of our county. So in just watching that without even the second surge, we've been meeting with the state elected officials on this. This is not just a county problem. It cannot be solved just by one county. You've got to find a way to rally folks around this. And one of the things we've been talking very frankly about is in the past, funding for public health has become in direct competition with funding for behavioral health. And that has to stop. I don't know how we manage this going forward if we don't find a way to build a partnership and integrate with behavioral health, because just we learned in the isolation and quarantine, you have to have both. You have to help people where they're at. You have to have a harm reduction approach. So we're in those active conversations. I think it's going to be just frankly terrible because I'm sure every state is starting to do their projections on their budget, and I know in the state of Washington, it's billions of dollars that are being lost. How do you leverage all these things and meet people's needs is going to be a huge issue for every council, every commissioner, and every state legislator. And we'll need to talk to our congressional delegation about how all this fits together. We tend to have lobby days on congressional hill days that are very separate.
Yeah.
Now's the time to unify. Now's the time to unify.
Yeah, I mean, I think that's a great point. So in our sort of advocacy communications, in addition to saying we need to fund local public health and state public health, we've been saying we need to fund states and locals because they're the whole of government at all of these different levels are going to see such decreases in revenue that it's going to affect everybody. So I think that's an important point. So there's another question. How did you build consensus among city and county officials for a unified response? I mean, in some ways you're probably used to balancing the city and the county, but any insight you could share on that would be useful for this person.
Yeah, well, I've had, I guess I can say I'm lucky. I've had years of experiencing working in the political realm because I, a long time ago, was a nurse lobbyist. And so building relationships has been sort of natural to my style. And I think that that's just been a benefit right now. One of the things that I try and do is I know that each elected official has the things that they're particularly interested in and that they want to highlight. So how do I bring forward what I need within the context of kind of how they are in their elected leadership role? I also I'm lucky I have strong support here in the King County, Seattle area. Both of the elected officials right now in a major city, which is Seattle. We actually have 39 cities in King County, and that's a whole nother story on all of folks who we're updating all the time. But the mayor of Seattle and the King County executive both believe in science. So number one tick, I'm lucky, and I will be the first to admit that. And I'm working with my colleagues around the state that aren't in that fortunate situation. But from that platform, then we strategically use the voice of the health officer. It's one of the advantages of me not being both the health officer and the director. It allows me to have Jeff's voice while I am working the operations and other type of strategy. So I think that's really helped because when then Jeff comes in the room, he can function as that communicable disease expert, which he is, as well as doing the health directives, et cetera. So I think it's kind of all of that landscape and just I'm fortunate that I've been here 6 years so that people know me. I think that also helps.
So we have a question on testing. How do you arrange and who performs and pays for testing for uninsured or underinsured populations? And then also, are you routinely testing or excluding traveling healthcare workers? So underinsured, uninsured, and then how are you handling healthcare workers with testing?
So getting testing kits, I think is a problem everywhere, and it's no different here. So we've actually worked with the State Department of Health on the testing priorities. So when we receive our test kits, we are prioritizing getting those out to partners who are particularly in that space of helping build access for low-wage workers, people on Medicaid, underinsured, and then undocumented. Let me add undocumented. So we will keep some of the testing kits so that our strike team, we do have a couple of strike teams that will do testing, but I really don't want to create a narrative that public health does all the testing. So we're trying to really use partners. So we get test kits out to the community health center system. We get them out to the providers who are helping us in the shelters. The City of Seattle has pivoted some of their emergency medical services personnel to help us partner in the long-term care arena. UW Medicine has pivoted some of their staff to do a mobile unit and work with us in shelter arena. And then, as I said, Permanente has been an incredible partner. And so we're trying to build those so that we actually have this matrix on which partner is going to be doing which testing where. And then we're using our data to show where there's areas of the county that have high needs for testing right now, knowing that testing's still limited, but we're still not getting all symptomatic people tested now. So working at how to use partners like our trauma and county hospital, Harborview, to do mobile testing out in that. So I think cobbling together these partners and working to get the test kits in the right place, and then monitoring based upon where you know you need to have more testing. Are you seeing that that's where testing shows up? And my epi team is we're trying to actually get some maps, visual, that are down to the zip code level. Right now, we have it a little bit bigger than that, but trying to get it down so we can activity happening. So that would be the ideal. Who pays for the test? This is a thing that sort of surprised me, that we have the situation where the state that all of a sudden surfaced as an issue that needed to be addressed. So if you work with partners who are willing to go ahead and do that testing where they can bill, because public health doesn't have a robust billing structure for all these, most of us don't, for all of these different insurance companies. So if you use a partner to do that and then get them to agree to basically bear the load for some of the folks that don't have insurance, that's one option that works. Otherwise, we are paying for that right now, and we're expecting either the CARES Act or other federal funding to help reimburse us for that while we work with the state on that issue.
So Patty, I know that you also have a new partnership with the University of Washington School of Nursing and supporting some of their, see, that was perfect. Making sure that some of their students have gotten their practicum experience given the outbreak, but then also supporting the work that you guys need to do in the community. So can you tell us a little bit about that?
Yeah, early on, when we were trying to, particularly as we were building our strategy for individuals experiencing homelessness and families who are living homeless, while we were building that strategy, I thought to myself, I'm going to connect with the University of Washington, because I was suspecting that their usual way of doing student practicum wasn't going to work in a pandemic. I don't know. So I called and make an appointment and found out when I got there that indeed, at least for the School of Nursing and the School of Medicine, all of the practicums had been canceled. And they were scrambling to figure out how to extend this practicum into the summer, which of course now we know probably wouldn't have worked anyway. And so I sat down and I said, can we brainstorm something really unique? And what we ended up doing, and we're now writing an MOU with 5 different of the schools. We started with the School of Nursing and the School of Medicine, but the School of Nursing basically was the first to get permission. They had to get permission from actually the the provost and president to shift, and obviously the licensing board, to pivot their undergraduate students over into our call center, as well as partners that might have similar types of opportunities. So they became core to our call center, answering questions, screening people. They were working with other nurses. It was a different type of experience, but it was an experience. And then for the graduate folks who are on the nurse practitioner track, we were plugging them in so they can begin to get experience using telehealth, telemedicine, and work with partners that way, as well as when and if we have to resurge again to do our assessment center, recovery center, they could actually get experience on site. So it was this range of opportunities for the school that worked really well for them and worked well for us.
Great. So we have one follow-up question on testing, and then we'll do one final closing question, and we'll let you get back to, I guess, start your day, or it's much earlier where you are. So the question is, once an asymptomatic person tests positive and is quarantined for a specific time, is there follow-up testing to see if they are still positive? And if so, what would be the next step?
Yeah, because of the limit on the testing, and I'm sure everybody's facing the same question, we have not in a jurisdiction that's gone down the road to try and do multiple testings. And now it seems like the science is really emerging that somebody can test positive for a very long time, but it doesn't mean they're doing any sort of transmitting of the virus. I think the science around that is really evolving. So we really anchor off the CDC guidance, relates to the number of non-symptomatic days and the number of days a person should stay quarantined if you're not really knowledgeable when they first became symptomatic. So that's worked all right for us. And I'm sure as the science emerges, and the world's going to turn really differently once we get a valid serology test. So that, once we start really understanding and being confident with an antibody test that it means if you have these antibodies. Right now, people can have antibodies and we're just assuming it means something. There needs to be more research around that. So all of that will be what's to come in the future for sure.
Okay, so last question, there's been lots of discussion about a second wave in the fall or the winter. And, we'll be dealing with this really until there's a vaccine. So knowing what you know now at this point in sort of this phase of this outbreak, how are you preparing for subsequent waves?
Yeah, so one of the things we're doing with our own team, but also with the modelers, like every university town, we have local modelers, and then there are those from around the country. I think this is another really important space for the public health community to work together on, is what are we asking the modelers to look at? So what we're actually doing is looking at what would a flu season look like if the flu season was a bad flu season and then you put COVID on top of it. And what would that mean to the healthcare system? Because right now we know in a really bad flu season, our ICUs have been full. Okay, so we've got to build off the assumption, okay, if that happens and you have COVID, what do you need to be doing with your healthcare system? We're doing the same thing in having the readiness for these isolation and quarantine. It might not be filled right now, but we're modeling, this is what we're seeing, and if it goes to here, how many of those space will we need? And then the critical point is now I need to build the support, the level of staffing we're going to need for that, knowing that some of these funding streams are like, well, COVID's going to go away by 2021. Well, like not. So how are we going to begin to build a trained workforce? Because I can't deal with the mental health of my staff if I can't bring in staff in between times, which is right now, to build some capacity. So all of those are moving parts that unfortunately give none of us a break in all this, even if we're tamping down the infection.
Well, Patty, thank you so much for being with us today and sharing all this. We're going to bring up a slide with additional webinars. So this is the second in our series. The recording of this session will be on our website, which is bigcitieshealth.org/events. Also, our first webinar with Sarah Cody and Tomas Aragon from Santa Clara County in San Francisco is up on the website. 2 weeks from now, June 3rd, we'll have Axides Barbeau from New York City, and then 2 weeks later, Muntu Davis from LA County, and we're going to continue scheduling these on. So please, everybody, register for our sessions, sign up for our newsletter so you can hear as we add more. And again, Patty, thank you so much. Keep doing what you're doing. Have a great day. Thank you.